How'd that look?
Hello, everyone. Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for July 15th, 2020. Thank you for joining us this month. We are excited to note that we are co-hosting today's webinar with the Alliance for Balanced Pain Management, which advocates, along with other stakeholders, for integrated individualized pain management strategies toward reducing medicine abuse and improving care for pain. Our presenter today is Dr. Amanda Nelson. Dr. Nelson is a board-certified internist and rheumatologist with a master's degree in clinical research in epidemiology. She directs the Musculoskeletal Ultrasound Clinic at the UNC Rheumatology Clinic and co-directs the Johnston County Osteoarthritis Project. Her research interests focus on the contribution of bone shape to OA risk, musculoskeletal ultrasound, novel methodologies for the analysis of imaging data, and assessment of whole body burden of OA. As an internationally recognized OA expert, Dr. Nelson was a contributor to the development of the 2019 American College of Rheumatology and Arthritis Foundation Guidelines for the Management of Osteoarthritis of the Hand, Hip, and Knee. She is extremely well suited to educate us about these guidelines in her presentation today. Welcome, Dr. Nelson.
Thank you, Kirsten. Can you confirm that you can hear me okay?
I can, thank you.
Thank you. All right, well, it's a pleasure to be invited to give this overview. There are a lot of papers out there to read, and I'm hopeful that by presenting this in a 30-minute lunch and learn that perhaps some of these guidelines will be a little bit easier to implement if you're not already. As mentioned, I am a member of ACR and OAAA. I'll mention the OAAA guidelines as well. I was a co-author on the ACR guideline. I'm on the editorial board of OAC, just so you know these things. And these are really my interpretation and opinion of the guidelines and not the official position of any of the involved agencies. So I hope that at the end of this, we can discuss how osteoarthritis is a serious disease. We can interpret the American College of Rheumatology guidelines for OA management and utilize them in our clinical care, and also understand the evidence around some of the more controversial therapies. So I mention this because sometimes we don't think of it this way. So a lot of times if you ask people what serious diseases are, they'll say cancer or heart disease or diabetes, but really osteoarthritis is in that category as well. And in 2013, it was the third most rapidly rising disabling condition, and it had increased pretty dramatically over the prior decade. All of these statistics are in a white paper written by OAAC. The reference is at the bottom if you want to have even more detail. Over 240 million people worldwide have symptomatic activity limiting OA of the hip or the knee. The majority of these have comorbidities as well, and the mean is 2 to 3, and a third of people with OA have at least 5 other chronic conditions. They experience excess all-cause and cardiovascular related mortality as well. These comorbidities then complicate our management options, as we'll discuss as we go through the guidelines. Osteoarthritis is challenging to manage. We have some interventions that can reduce pain and improve function, as we'll discuss, but there's no cure. We can't achieve remission. There's really no effective strategy to reduce progression of osteoarthritis. There is no proven way to prevent the eventual need for a joint replacement. The structural damage experienced in osteoarthritis is irreversible and progressive. And the available pharmacologic treatments are associated with significant adverse events. So that's not very encouraging, but we'll talk about how we can get around some of that. Certainly a one-size-fits-all strategy is not appropriate. So patients have different comorbidities, they have different preferences, and really tailoring the strategy is essential to success. So I'm going to briefly introduce how these guidelines were developed. All guidelines are a little bit different, and it's important to understand where they come from to see what their limitations are and how they might be applied or maybe not applied. The ACR guideline was developed by a core expert panel, so they really drove the process. There was a literature review team who systematically reviewed the literature that I'll mention. There was a patient panel, so there was patient input throughout the process. And there was a voting panel. So based on the literature and the patient input, the voting panel voted on appropriateness of the various potential interventions. The guideline was used a literature review that was updated up till August of 2018. So it does not include things more recently. It takes a long time to get things finalized and written and published, and so there's a gap between the most recent research and the guideline. The review was based on PICO questions. This is patient or population, intervention, and comparator groups. So essentially you're asking the question, is this intervention better than this intervention in a given population? And those questions are generated first, and then the literature review is around those questions. So that's really how it's structured. And the grade method is just one of the many methodologies that can be used in order to generate a guideline that all ACR guidelines follow. So if you've read any of them, it's the same process. This particular review focused on randomized controlled trials. So some focus more on reviews and meta-analyses in particular. In this case, the goal was really to go to the original trials and assess the information from those. There were some very high impact meta-analyses that were included for some of the topics, but the goal was really to find high quality randomized controlled trials and base the guidelines off of those. Certainly there's expert opinion, so I mentioned all the different panels of people, and evidence is often inconclusive or does not directly reflect the question that was asked. And in those cases, there's certainly a large component of opinion. The recommendations are in the form of either in favor or against a given intervention, and then whether that's strong or conditional. So it could be strongly in favor, conditionally against, any combination of those. And you'll see that as we go through it, but just to know that that's the structure of how these were generated. In the introduction of the paper and through much of the discussion around the development of the guidelines, there was really an emphasis on the need for a multimodality approach. So in no case is it an algorithm of one thing, then the next thing, then the next thing. It's really lots of things all at once, and then moving on to another set of things. This comes into the tailored approach, so really trying to account for the beliefs and preferences of the patient, what they would prefer to do, what kinds of things they like to do, what their goals are. It's important to consider their general medical status, some of the comorbidities, as I mentioned earlier, their access to care, access to some of the recommended strategies. There's a breadth of symptoms involved in osteoarthritis, so it's not just pain in the knee. It's pain in lots of places, it's mood alterations, it's difficulty sleeping, it's coping with that pain, it's their home environment, the work environment, whether or not they have social support. So there's a lot of things involved in a given patient's experience of osteoarthritis that can, in some cases, be incorporated into the plan, and understanding sort of where they're coming from is really important. As I go through these, it's important to note that these are all interventions that are recommended in addition to what was called usual care. And usual care, as outlined in the paper, was sort of intermittent use of over-the-counter NSAIDs or acetaminophen. So sort of assuming people have already tried some things for this, and this is the next step that they go through with their provider. There are two ways that the information is presented in the paper in addition to the text. I'm going to show you both of them. This is for the figure people. I am a figure person. I will give you the tabular person version of this in a minute. And so I'm going to walk you through this because we're going to see another one in a minute. Let me get, oh, sorry. Get my silly pointer to work here. There we go. So as Kirsten mentioned at the beginning, these are for the hand, the knee, and the hip. On the left side of this slide, you see the physical, psychosocial, and mind-body approaches. This, in prior iterations, has been called the non-pharmacologic approaches. We really felt that non was a negative connotation that is absolutely not warranted for the osteoarthritis population. So the goal was to try and rename it, although it got a little bit cumbersome, into something more positive and sort of framing this as definitely useful and important in the management of OA. Then the pharmacologic approaches are on the right, again for hand, knee, and hip. As I mentioned, strongly recommended are colored in darker green, and conditionally recommended are outlined in green. And so this is just an overview figure, and I'm going to talk about several of the recommendations in more detail. This gives you kind of a quick look or a way to go through them with patients or other groups as you see fit. Obviously, exercise is going to be a main focus here, and you can see the things that are strongly recommended versus those that are conditionally recommended. So the strongly recommended interventions, as I highlighted, exercise was felt to be important for all the sites, regardless of anything else that's going on. There is a lot of evidence supporting exercise. The evidence is somewhat general in that it does not reflect a given form of exercise. So aerobic exercise, you could say, is reasonable, but there is evidence for land-based, aquatic, different forms of exercise. And the committee really decided not to try and parse that out, but rather to say that exercise in a form that's acceptable to the patient and available is absolutely recommended for all forms of osteoarthritis. Self-efficacy and self-management are sort of accepted as general good practice. There's not a ton of evidence, and the effect size for these is very small, but there was really no reason not to make them strong recommendations. So these are not things that are going to solve the problem, but these are all things that should be part of the strategy. At the knee and the hip, weight loss was similarly a strong recommendation for individuals who are overweight. There are scads of papers about the importance of weight loss in controlling the symptoms of osteoarthritis and likely addressing some risk of progression as well. Tai Chi has a growing body of evidence that it's likely useful. There's really no downside to Tai Chi. The risks are so small that this landed it in the strong positive recommendations. Walking aids, when needed, similarly have little downside. Certain braces at the thumb and at the knee were in the strongly recommended category, again, because of reasonable evidence and little risk. Oral NSAIDs land here primarily based on efficacy, so they're very useful, but often are limited in their ability to be utilized in certain patients due to risk, primarily gastrointestinal and cardiovascular risk, as we're all aware. At the knee, topical NSAIDs also received a strong recommendation, given more data really for the knee than for some of the other sites. And at the knee and the hip, intra-articular corticosteroids were also strongly recommended. Some conditional positive recommendations. Now, this doesn't necessarily mean they're not good, but it might mean that there's less evidence. It might mean that there's more risk. It might mean that there's just not the strong body of evidence to back these things up. So they're conditional. We think they're useful. They just don't reach the strong threshold. So these are things like heat and ice, paraffin baths for hand OA, cognitive behavioral therapy. There's been more work on since the last iteration of these guidelines in 2012 and appears to have some benefit. Acupuncture, similarly, little downside other than some cost and access issues, but the benefit seems to be reasonable as the literature continues to develop. Some additional low-risk things like taping. Balance exercise, again, just wasn't studied as much as aerobic exercise. Some other kinds of braces and yoga. Topical NSAIDs for sites other than the knee, again, just less studied. Chondroitin and intra-articular corticosteroids for hand OA. So I mentioned corticosteroids for knee and hip being a strong recommendation. Again, hand OA in general is much less studied than knee and hip. And so it just doesn't quite rise to the level of a strong recommendation. That doesn't mean it's not good. And then acetaminophen has fallen. It used to be in the strong recommendation, kind of first line, but it has declined really due to two things. One is a cumulative reduction in what we think the effect size of acetaminophen is in osteoarthritis, and the second being an increased recognition of side effects from acetaminophen at the doses that are needed to really achieve that effect size. For tramadol, the issue is more risk-benefit, and for duloxetine, it's a minimum amount of literature and sort of it's a little bit newer and there just isn't the widespread experience. So these things are in conditional. It does not mean they're not good. It just means that they are not as supported. So this is the tabular view I mentioned. This is for the physical and mind-body intervention. So they're listed out here in more detail. You get the joint sites across the top, hand, knee, and hip, and then the strongly recommended in green, dark green, conditionally recommended in light green, recommended against in red, and conditionally against kind of in pink. If they're white, it means that there is no recommendation. So that either means there was no literature, this was not a PICO question of interest, or some such. So it doesn't mean it's good or bad, there is no recommendation for or against. So this is for the tabular people and kind of gives you a little more detail about the individual interventions if you're really interested in one of those. And I'll show you that again for pharmacologic in a bit. Moving on to the not recommended strategies. So same layout, physical, psychosocial, and mind-body approaches, hand, knee, and hip. Now we're looking at bright red is strongly against and light red is conditionally against. You can see TENS is listed here. That was based on studies that were done and did not show benefit. Some of these things, like manual therapy, there's clearly benefit from the exercise, and it was a little bit hard to tease out whether the manual therapy had its own benefit, which is why it was conditionally against. And some of these others just really didn't have strong studies to support them in the given joint site. Pharmacologic over here. At the top are agents that have been tested in randomized controlled trials and have not been effective. There's actually a very recent one on bisphosphonates, but these things don't work and therefore should not be used. And the panel was pretty clear and gave a strongly against recommendation for all of these at all sites. PRP, which is platelet-rich plasma, and stem cell injection I will come back to shortly because this is a question I am always asked when I give these kinds of presentations, so we'll talk more about that shortly. Chondroitin, so glucosamine ends up in the no group, chondroitin's kind of in the maybe group for hand. Hyaluronic acid is also conditionally against. This is another one that we're going to talk more about in detail in a minute because I'm always asked about this. And then some other ones where it seems like the risk probably outweighs the benefit, or maybe there are not sufficient studies to make a clear determination, but they ended up in the conditionally against category here. So the strong against recommendations, again, to summarize, TENS, which is a neural stimulation at the knee and the hip, bisphosphonates, as I mentioned, glucosamine, mainly due to issues of publication bias and really lack of efficacy in well-done randomized controlled trials. The other sort of biologic RA type medicines that I mentioned on the last slide. And then again, we'll talk about some of the injectables shortly. Conditional against, just highlighted some of these. Again, we'll talk about HA, just to kind of give you a couple of different ways to process this information here. And then our tabular view, so interventions here, these now being all pharmacologic, hand, knee, and hip here, same color scheme. It really says the same thing, but gives you just a different way of looking at it. All right, so intra-articular hyaluronic acid is controversial. Many of these things are not, right? So one thing I always like to emphasize is that exercise and weight loss and NSAIDs in whatever form is acceptable are not controversial. These are things that work for people. But some of these other agents that end up being kind of second line have more controversy in the literature, and we get focused on that. But there are a lot of things we can do for OA that everyone agrees on and we really should be doing. So intra-articular hyaluronic acid, really at the knee, was not recommended in the ORCE guidelines in 2014 or the orthopedic guidelines in 2014. It was a conditional recommendation by the ACR in 2012. This image is from the 2014 ORCE guidelines. So they did it a little differently at that time. So on the left, we see knee-only OA in an otherwise healthy person, knee OA in a person with comorbidities, multi-joint OA without comorbidities, and multi-joint OA with comorbidities. And they're recommendations were sort of in the appropriate or non-appropriate range. They give a risk and benefit score. And so the benefit and appropriateness for knee OA only was uncertain, and it was thought to be not appropriate for multiple joint OA, which kind of makes sense. Then it was conditionally recommended by the 2019 ORCE, the updated ORCE guidelines, and as I've mentioned, conditionally not recommended by the ACR 2020 guidelines. So what do we do with that mess? There have been many reviews of intra-articular hyaluronic acid. I just pulled some examples to discuss some of the issues around these. So this was one that garnered a lot of press a few years ago. It was in the Annals of Internal Medicine. Was a systematic review and meta-analysis of 89 trials with 12,000 people, and found an effect size that was significant. It was almost 0.4, which is in the range of oral NSAIDs. It was dependent on some trial characteristics that we won't get into, but they really emphasized a high risk of adverse events that was kind of surprising to a lot of us who have used these agents and really haven't seen that. But there was sort of post-injection flares and other issues, and they ended up really not recommending HA based on their review. Then around the same time, there was one by Banuru et al. Out of Tufts, used slightly less trials, found a very similar effect size, so 0.3, and emphasized the time course of HA. So one proposed benefit of HA over, for example, corticosteroids has been that we think it might last longer. So where corticosteroids maybe last 2, 3, 4 weeks, maybe HA lasts 8 weeks, which is really what they found here, not so much 24 weeks. And they sort of emphasize, well, maybe this gives us a more prolonged benefit. This one came from some of the updated ORCE guideline co-authors, and this is the actual title, Why We Should Definitely Include IAHA as a Therapeutic Option in the Management of Knee OA. 17 meta-analyses, most of which were positive. The effect size is the same, so we're interpreting these differently, but the effect sizes are really the same. This included a network meta-analysis specifically focused on adverse events because of that prior study I had mentioned. And really found a low incidence of adverse events. So these authors recommended that HA was appropriate for mild to moderate knee OA when it's clinically and radiologically confirmed, and there's been a lack of response to other treatments. So not recommending it as first line, but as reasonable. And so what do we do with all of that disagreement and challenges? So meta-analyses themselves do not address publication bias, right? So it's a meta-analysis of published studies. And so it does not deal with studies that weren't published, negative studies that are still on somebody's shelf somewhere because they didn't want to publish a negative study or couldn't get it published, which is a challenge in the literature in general. As I mentioned, studies that are published are sometimes industry funded, and there's this concern that maybe they're a little biased. Any biases that are in the published randomized controlled trials are also not addressed by meta-analysis. There are some methods to try and deal with that, but the study is the study and its issues are its issues, and those are still present even if we meta-analyze it. The treatment is expensive. It can be time-consuming. There certainly are one-time injections, but there are also every 5-week injections that are recommended that people get every 6 months, and they're in the office, getting their knees injected most of the time. There are dramatic differences geographically, by specialty, interpersonally. People have strong opinions about this based on whichever studies they read and believe. And so, and I don't pretend to be immune from that, and I don't think anyone should pretend to be, but to try and take, all of that into consideration, I think the likely best place for hyaluronic acid is a reasonable second line option. It's not going to be the first thing we should do. We shouldn't say you have knee OA, here's a shot, but probably does have a place and is probably a reasonable approach given the evident safety and the likely benefit. So I mentioned I would come back to PRP and stem cells because that's always the question. So there's a challenge with standardization here. So at least HA, we know what HA is. You get a certain product and you know what that product is. You do PRP, who knows, right? So even if you use a standardized kit, you're using material from a patient, and that material then informs what the product is in the end. The terms themselves are imprecise and don't really tell us what we're doing. And so there was a review of platelet-rich plasma in 2017. The references are at the bottom. It found 16 randomized controlled trials, but most of them were small. They usually compare to HA, not to steroid or to another a control group. They were all of low to moderate quality. That group determined that they felt like this product was likely safe. It has a potential for symptomatic relief, but the evidence to that time was not definitive. And they published an RCT protocol. I believe that they're wrapping up enrollment in that randomized controlled trial, which may answer some of these questions. For mesenchymal stem cells, it's even worse. So there were 61 clinical studies in this review that's noted at the bottom. Most of them were case series or reports, so they were level 4 or 5 evidence for the orthopedists in the group. There were 4 different types of stem cells. All of them have different processing. All of them had different adjuvants. There was really no consistency across the studies to be able to even compare them as the same treatment. In those studies that were of better quality, all of them reported improved pain, but the issues of the study design themselves sort of limits our ability to interpret that. Again, probably safe. Most people tolerate these fine, and there may have some benefit, but we just really don't have the evidence, and all of the society guidelines are really based on the published evidence. And so if that evidence isn't there, those societies are not going to strongly recommend these things. So the conclusion in the meetings and based on these reviews is that there's just not the convincing evidence that these are safe. There's some concern that over time they could even be harmful, right? So we don't know what happens if you take these things and inject them into, and you do then inject, new inflammatory cytokines that over time can actually damage the knee. We just don't have the evidence to be able to really make an educated recommendation. So as I mentioned, the review ended in 2018. There certainly are other things published in that gap, and also things that are in development. So I thought that there might be a question or two about anti-nerve growth factor. There's a monoclonal antibody that is under review at the FDA. That's a long story that I could give an entire talk about, but certainly that is still in process as far as I know, and approval is expected, although it may be quite restricted. There's an FGF18 product called Sprifermin that's in phase 3 trials and has been published that shows structural benefit. So the NGF is all symptomatic benefit. The Sprifermin is all structural benefit with no apparent symptomatic benefit, which is interesting. And then there's a Wnt inhibitor called Loracivint. I don't know how they name these things. That's also in phase 3. There are many other agents that are in earlier, like phase 1, phase 2, or even preclinical studies. So there may still be progress in this area for sure. So take-home points, OA is a serious and heterogeneous disease. The most effective currently available treatments are non-pharmacologic or physical mind-body, as we discussed. You can help. So, you're part of the OA Action Alliance. We greatly appreciate that. You probably are aware of Walk with Ease. There are programs like Walk with a Doc that help us to go out and become more active with our patients. As I mentioned, there is substantial agreement across guidelines for many therapies. Uptake is still suboptimal even for those things. And then the other controversial ones, as we discussed, what we have is certainly not satisfactory. So we're hopeful that through ongoing development, we'll get some even better ones in the future. So I will stop there, and sorry, I'm just at time, but if there's a few questions, we can hopefully answer those.
Thank you, Dr. Nelson. Yes, anyone who has a question, go ahead and type it in the chat box. We will stay on for a few minutes over to address any of those for discussion. One thing I did want to say, I think it's really helpful that, these guidelines, most of us see in black and white print on paper. It's really helpful to get a little bit behind the curtain with your insights and how the group decided to develop the guidelines in the way that you did. It's really helpful to understand some of the nuance and all of the data that went into it. You said at the very end that uptake is suboptimal. How could that be improved, or how are these guidelines disseminated to clinicians or other healthcare providers who treat OA who may not necessarily be rheumatologists or subscribe to the ACR journals and so forth? How does that get better disseminated?
Yeah, so I think that's been one of the challenges, and certainly not just for OA, but for chronic disease in general, is trying to get, we can talk till we're blue in the face about what's good for patients, but if it doesn't get out to the providers and to the patients, it's really not that useful. So, generally these are stuck in the journals, right? So they're maybe published in several journals simultaneously. There's maybe a press release. There's sometimes infographics and things, but I think places like the OA Action Alliance and the Arthritis Foundation and some of these places that disseminate things more broadly are really important to trying to reach the target audiences for these things.
Thank you. I think that is helpful, and I'll put in a shameless plug for the OA Action Alliance's OA Care Tools Primary Care Toolkit that does highlight these guidelines and goes into some depth about them. So that's definitely a source. One question came in: since exercise is so effective and beneficial, how do patients learn the most appropriate exercise and how to start?
Yeah, so I think it depends a lot on the patient. So certainly some people you can sort of walk through a walking program. So I have, for example, a prescription that I use that goes through my electronic medical record that allows me to say, you need to walk for 10 minutes, 5 days a week or something. So if a person is motivated and you think they can sort of self-start with some of these things, I think a walking prescription is a really good place to start. If they're overly limited or they have some other sort of complicating factors about being able to do this themselves, I have a very low threshold to send people to physical therapy, occupational therapy more for hand, to try and get them started. Even for a one-time visit, I'll send people just a consultation, go see them, talk through what's safe, what's not safe, how you can get started, how you can ramp that up over time, get a home program and go from there. So I think that's one of the things that really has to be tailored. And that's why it wasn't prescriptive in the guidelines. It's really what people can do and what they're willing to do.
I think that gets at this next question I'll skip ahead to that's also related to exercise, is what is the intensity of exercise that is beneficial for this population but not harmful? And I suspect you're going to say that's highly individual, but certainly go ahead.
It is. And so this prescription I'm talking about, I can change the parameters. So maybe what I really want them to do is 30 minutes, 5 days a week, but they haven't moved in 2 years. So we're not going to start with 30 minutes, 5 days a week. So I have changed that thing to 2 minutes, 1 day a week for somebody. So, sometimes it's standing up more than sitting down. And so sort of seeing, it takes a few minutes of conversation during the visit to try and see what they're starting from. But if you understand that, then it's much easier to see how you can get them to their goal. And starting slowly is very important, because if you get overly aggressive with your goals, then people get frustrated and they give up.
Yeah, I think that's extremely important to consider. Switching gears just a little bit, we have someone who says, I am not familiar with the terms, but my rheumatologist is recommending cortisone. Was that the one studied? I think there is some confusion about what. Absolutely.
So cortisone usually is going to mean intra-articular corticosteroid. And there are many different kinds of intra-articular corticosteroid, which is why that's sort of the generic term. You can use triamcinolone, you can use depomedrol. There are different formulations, but people often think that steroid and cortisone they reflect the same construct, but they're just a little bit different. So it probably was related to intra-articular corticosteroid.
Thank you. So what are the thoughts and recommendations on group therapy or rehab appointments as compared to one-on-one therapy?
Yeah, and we talked about that a little bit. And it's one of the, I know I keep saying the same thing, but people are just so different. And some people love being in a group and they love the camaraderie and they love working through challenges with other people and seeing that other people struggle with what they struggle with. And other people don't want anything to do with that. And they don't want to be in a group and they don't want to talk to anybody and they just want to do it themselves. And a lot of the programs that are out there that are evidence-based, Walk with Ease being a key one, they have different ways to do it. So you can do it in a group with a teacher, or you can do it on your own with a workbook. And I think it doesn't really matter as long as the person buys into that program and they're comfortable with it and they're going to do it. And it doesn't, which form they choose to do it in really is not that important.
Great. Just typing into the chat box, I wanted to endorse the comment that the OA Action Alliance Director, Lee Callahan, put in there, that thinking back to an exercise prescription, this could also include a link to the OA Action Alliance's Walk with Ease page, which is what I just put in the hyperlink right below that. It's called walkwitharthritis.org. Walk with Ease is an evidence-based program that Dr. Nelson mentioned a little bit earlier. It advocates for starting slowly depending on where someone is. Also currently patients can get the Walk with Ease guidebook for free from the OA Action Alliance if they participate through us. And that is quite a comprehensive guidebook that is more than just walking. It also talks about stretching and what patients should expect, people with OA. So definitely check that out if you are looking for resources to give to patients. So I don't see any other questions that have come in to the chat box. I wanted to thank everyone for joining us today once again, and just give a quick note to look ahead to August 19th for our next Lunch and Learn webinar with Dr. Timothy Griffin from the Oklahoma Medical Research Foundation, who will present on obesity and metabolism in osteoarthritis for those who are interested. So I will end our session today with a big thank you to Dr. Nelson for your presentation, and to the Alliance for Balanced Pain Management for their co-hosting. Thanks, everyone.
Thank you very much.